let's look for another clinical case. Akif, can I move on? Can I go a little bit further, like past like an extra half an hour? Can I?
Yes, dear. Now you 1 hour's passed. Now I think we have the 30 minutes.
Oh, perfectly. So I don't need to rush.
No. Please be relaxed.
Oh, thank you very much. I will open it.
Don't move fastly because we want to learn your ideas. Thank you.
Thank you, my friend. So let's move on. Let's see another clinical case. This is André. He also came from a previous orthodontic treatment, but now he claims about the anterior open bite that was not solved, okay? And he was asking about small upper teeth, but as we can analyze here in his smile, his picture, I cannot extrude those upper incisors. They have a nice gingival display, okay? So let's try to, let's look in the occlusal views here. And I can see that his class 3 with an anterior open bite, as noted before. This open bite was extended until the premolar area, and there was already some retroinclination of the lower incisors. So we're trying to solve it, and we thought, oh, let's try to work with aligners, okay? And he said, okay, that's great. That's my first option as well, because it took me so long, my previous ortho treatment with fixed appliance, that I'm sick and tired of that. And I said, okay, let's work with aligners. This is just a tool. The orthodontist is the main key here, the main aspect of this equation, okay? I need to use the tool that I think it fits on you. And if he said, okay, I will say, okay. Open bites perfectly, as you all may know. But this is the initial radiograph, the lateral view of the radiograph, cephalometric analysis. The A and B is -2. The lower incisors were already compensated, as we talked before. It's a little bit vertical growth. The SNGOGN was 36, but it's okay. We can work on that. In the past, for a treatment like that, I would use TADs, okay? Nowadays, I use aligners. And here, I will see the clean check. I was intruding upper molars, intruding lower molars, and also extruding the lower incisors to close the bite. Okay, let's have a look on it. Okay, so we can see here a little bit of intrusion on the upper molars, on the lower molars, and that's why I designed these attachments on the premolars. Look, let's have a look here. The intrusion of the molars, and then a jump. Can you see the jump? The jump brought the mandible backwards. Will that happen clinically? No. No. But why do the clean check shows me that? Because the clean check cannot see the anatomy of the joint. So when I have a vertical bite jump in the clean check, it's always vertical, or in that specific case, it was vertical and backward. Okay? But that's not how it works clinically. Clinically, it's also always vertical and sagittal, bringing the mandible forward. Okay? Because it has a hinge in the joint area. So I need to program cuts to use elastics. mainly in class 1 and class 3 cases. Otherwise, I will have an anterior heavy contact or even a crossbite if the vertical jump is too big. So be careful with class 1 and class 3 cases, okay? Oh, Guilherme, Dr. Thiessen, how much is this hinge? There's no information in the literature yet, but I have a paper published in 2017 with friends from St. Louis University. It's a sample collected that by Shuka Moshiri, the sister of Dr. Mas Moshiri, my great Invisalign mentor in St. Louis. And here I published this paper with Shuka, Dr. Araújo, Dr. McRae, and Dr. Ki-Byung Kim, the head of the department there. And we saw that there was this is a case on the sample, that we got some intrusion on the molars, we got some closing of the mandibular plane, and I could see in some of these cases, as well as in my cases here in my office, that for every 1 millimeter of posterior intrusion, it may happen rotation of the mandible leading to 0.7 millimeters of sagittal anterior reposition of the lower arch. So I need to take this into account. I need to count with these changes happening. And I cannot believe only in the vertical jump provided or shown to me by the CleanCheck software. So let's come back for the treatment. So I need to use, yes, it was class 3. I need to use a lot of elastics. And I need to show the patient that he will need to use it. So I also added some attachments on the lower incisors, as you can see, because I needed extrusion of those teeth. I wanted intrusion of the molars. So that's why I also added attachments on the premolars, because I wanted to intrude the molars and close the bite. That's the final result. 11 months of treatment, no refinement was necessary. This is André, the end of treatment, and the final result. Let's have a look, initial and final. And I also left him some space for build-ups on the centrals. Initial and final. Remember, he claimed about small upper centrals, and I agree with him. They are kind of square. They need to be longer than wider. So build-ups were necessary, initial and final. Unfortunately, I don't have the build-ups because he moved from the place I live, but I tried to contact him some weeks ago, and he said that whenever he can, he will come to visit me. Initial and final. And let's have a look at another clinical case. This is a nice one. This is that deep bite with full cusp class 2 that we saw in the beginning. The patient was referred to me by his periodontist because he had major gingival problems in the inferior region. Why? Because of the deep bite. So here we can see a class 2 subdivision. So it's a class 2 div 2 subdivision because only the left side was class 2. The right one was mainly class 1. Severe deep bite, as you can see, it not only 100% deep bite, it's 110, may I say. And mild crowding, okay, in the upper and lower arch. So will I do proclination with intrusion? Okay, yes, as we saw before, staging would be performed like that. But will that proclination correct the deep bite? No, it's too huge. So it's huge, and that's deep bite. The upper teeth were like grinding the lower one and grinding and smashing the gingival tissue in the lower anterior area. Let's see the initial radiograph. Can you see here the step between the premolars and the incisors? Look at that. Look at that. Some other radiographs. Here's the initial radiograph and the cephalometric analysis. There you are. There you are. Look at these numbers. these teeth are retroclined. Let's see the clean check. Wow, huge attachments. Why? Because I need attachments and I open space so the plastic would wrap the whole tooth, the whole teeth, and I needed big attachments because I needed a lot of torque. Oh, you have other features for torque, the power ridges, but when they come in many teeth together, I try to remove and add these big horizontal attachments bevel to the gingiva. We're going to talk about that soon. He also had a jump to correct the sagittal class 2 on the left side because I added a lot of elastics.
It's okay, you were here.
Perfect. So as we are talking about the clean check and a great intrusion with overcorrection of the leveling of the curve of Spee, okay? As you may see here. But we are talking now about the torque of these incisors. Let's talk about power ridges. Dr. Tizen, do you use them? Of course I do, they are great. But sometimes when they come with many teeth sequentially, side by side, I change it. Okay, that's my tip for you. Why? Because since they are like bumps, they don't put a great contact between the plastic and the teeth. So I change for these attachments I showed you before. Another tip is that usually I take the last molar as a reference, extruding the molars and premolars and intruding canines and incisors. But sometimes when I don't have a lot of proclination of the incisors, I add some overcorrection on the incisors. How much? 1 millimeter. In that case, I added in the upper and lower arch. Why? Because I think that if we don't address properly the vertical, we cannot address the sagittal. Some people say that their techniques are based on sagittal first. Here, in these deep bite cases, using aligners, we need to think different. We need to think that vertical is the first thing to address. That's why I did all that overcorrection. Another important topic, as we mentioned before, using attachments, is that attachment that is planned for rotation and it's triggered by the software. We need to change it. Okay? We need to change it. In the premolars, can you see that? And also, I'm adding more attachments for leveling the curve of Spee. What attachments are necessary in my opinion? Attachments for molars, because I need to extrude them, and attachments in the lower incisors, or even in the central lower incisors, if these incisors are misplaced, are malpositioned. Why? Because I think that it has a better control on the intrusion of the anterior teeth if I add some small 3 millimeters horizontal attachments. And as I told you before, I love to bevel these attachments. So here it's another tip for you guys. Let's look this case. Oh, Gui, but you said that you love these new optimized attachments. Yes, I love these big ones, but by the time I treated this case, I didn't have that option yet. So I changed a lot of these attachments. Oh, Gui, why didn't you put these attachments on the lower incisors, as you mentioned before? Because the deep bite was too huge. I was not able to place any attachment on it. In the additional aligners, I did put some attachments on these teeth, but on that first set of aligners, I did not. So, as you may notice here, the dark teeth indicate huge and difficult movements. But let's look how it will work. class 2 elastics on the left side. It's 1/4 inches of medium, it's 6 ounces. 6 ounces is heavy. This one is heavy. 1/4 elastics on the left side. Oh, Dr. Tizen, does this tilt, inclinate, cant the occlusal plane? I cannot see that in aligners as I was used to see in fixed appliances. So when I use only unilateral elastics, it works fine, really fine with aligners, okay? But let's see how it's working here. Look, it's improving the sagittal relationship and the overbite. Look, now we are finishing the first set of aligners. It's stage 75. It took so long. Yes, it did. But it was a really difficult case. And now I'm changing a little bit the protocol of elastics because I need intercuspation on the posterior teeth. So that's how I can see the first set of aligners finishing. So this is the evolution of treatment. The first column in the beginning, the second column midway, and the third column after the first set of aligners. I need a little bit of refinement. Yes, I do. But look at that. This is a beautiful case in my opinion. Look the overcorrection I did. That's why I told you before, this is just a cartoon. This is the fourth system that I designed on the clean check. And these are the results here in the third column after this first set of aligners was implemented. Okay? Now I needed some additional aligners. I did some torque, I did some IPR to close some black triangles. And that's the movement I wanted on this refinement, on this additional aligner set of aligners. So here it is, the patient using and finishing the occlusion, finishing the ortho treatment, okay, settling the occlusion, and this is the final result. This is the final result. 24 months of treatment, it's a long treatment, okay, but it's a difficult case, in my opinion. And here it is, the final results. Initial Invisalign treatment and final results. The first line is the initial condition, and the final line is the final occlusion. Initial and final, initial and final, initial and final, and here it goes. Can you see the leveling of the curve of P here? Great, isn't it? There you are. And I will move a little bit faster because I have two cases that are quite nice and I want to show you. Initial and final, initial and final. There you are. Cephalometric analysis, it's quite nice. And post-treatment results, 6 months, but it's quite stable, quite stable. There you are. How much time do I have, Akif, yet?
I think 10 minutes, it's okay.
10 minutes? Okay, so I will skip a case, okay? Let's skip a case. And our last case will be this young girl, Sophia, it's her name. Her chief complaints were statics and breathing, mouth breathing, I mean. She had the left joint clicking with pain and upper central incisors with asymmetric smile exposure. It was a cant actually in the maxillary occlusal plane. This case is published in the Invisalign Global Gallery, okay? So the initial conditions were also a retreatment, but it was a class 2 subdivision with asymmetric mandible. Boton discrepancy was also present. And a major issue here was that the patient was planning to live in Spain within 3 months from this first consultation. And that was a short period of time to treat this kind of patient with that complaints, with that desires to do orthodontic surgery. So this is another view of the situation. Okay, the asymmetric mandible here can be seen, and the maxillary compensation of this mandible, this asymmetric. Here we can see the digital models, and if we de-occlude them, we can see the asymmetric positioning of the upper teeth and the lower teeth. Okay, here we can analyze all that situation. Here, the initial pan and the cephalometric analysis. The A and B is huge, and the occlusion was trying to be compensated by the previous orthodontic treatment. Here in the CBCT that we requested, we could analyze properly the asymmetric condition of the body of the mandible as well as the ramus. Okay. And the CBCT scan is here. So we can see the whole condition, teeth, jaws, canths, everything. Because now we need to be precise. We need to achieve perfection. So here it is, the condition again. And the treatment plan included bonding the attachments and IPR prior to the orthodontic surgery that was chosen by us, by the team, to be a surgery first protocol. Okay, so before the surgery, we bonded all the attachments, we performed the IPR, adjusting the bolt-on discrepancy presented. Then we did the orthodontic surgery to harmonize, to equilibrate the position of the jaws. Then after that, we started leveling and alignment with the use of intermaxillary elastics for intercuspation. Let's have a look. Here it is. Can you see the jump? Yes. So the jump was the surgical procedure. Here, okay. Oh, the patient said, I want to move to Spain. Okay, so the Invisalign system is perfect for you. Why? Because it's better for someone there to monitor you after my treatment here, because I won't be able to finish it, I thought. Then everything worked perfectly, as you will see soon, and we finished the treatment before the patient moved to another country. So here it is, surgical procedure and ortho treatment, leveling the teeth, correcting the bite. Another tip here, why did I change the attachments on the canines? Because I had a cut. So there you are, I changed. Because by the time I did this treatment, there was no bigger sized optimized attachment. So let's see the jump and the ortho treatment after that. The jump was the vertebral simulation of the surgical procedure, okay? That's how I used to do with my surgical team before. Now I'm gonna give you a tip that's improving even more our results. But look, the lower IPR to adjust the bolt-on discrepancy. And let's have a look. This is the 3D digital planning, the initial condition, the vertical planning of the surgical procedure. What's the problem here? Because Invisalign does the movement as I request. But look at this. Can you see the occlusal contact, for example, here? And there was also some occlusal contacts that I cannot see here. And that was some instability that I was adding to the treatment, to the occlusion after the surgery. And here is the final results. The virtual planning of the orto-surgical procedure. Now, to avoid these occlusal interferences, what do? My new protocol is to register the bite jump by occluding a printed models and not asking to clean check to do that. So it avoids unwanted occlusal contacts after the surgical procedure. And there we have more occlusal stability. Okay? Oh, Gui, why don't you bond some brackets or wires or whatever on those teeth to get stability? Because I think that since the patient chose, and I chose for aligners, it's gonna be aligners all treatment long, okay? So there you are, the 3D planning. The surgical procedure here, it was done by Dr. Jonathan Klaus, a good friend of mine here in Brazil. And here's the bimaxillary orthodontic surgery with chin reposition. There you are, the movement all done and the big change. So the maxilla was advanced, impacted asymmetrically to adjust the cant, and the mandible followed all of it, and the chin was also repositioned. Okay? Here are some of the movements. In the anterior nasal spine, in the upper central incisors, and in the chin. How can I get more stability after surgery since I don't have braces? I keep the splint of surgical guide during some time to stabilize this post-surgical occlusion. And nowadays, as I shown to you before, I scan printed models. Okay? How long do you keep this surgical splint, Guy? And first of all, how did you get this idea? I got this idea from Dr. Wang, a great Korean orthodontist that I had the opportunity to interview in Dental Press Journal of Orthodontics some years ago. And he's an expert on surgery first. And as you can see here, even for cases with braces, where the occlusion is very unstable, he used this surgical splint for some extra weeks. So I had the idea, I talked to my surgeon, and we said, let's move on. Let's not bond braces. As I must confess, I did in my previous orthodontic cases treated with Invisalign. Now I don't do anymore. I keep this splint. This is not the same patient, but I'm just showing you. This splint is fixed by DATs, and these same DATs can be used for placing elastics. How long the surgical splint is maintained in the patient's mouth? It varies from 15 to a maximum of 90 days. How can you choose which patient is going to use 15 or 90 days? The instability of the surgical procedure. We all know from the papers from Profit and colleagues that are surgeries that are more unstable, as we can see here with these red arrows. But there are also some surgeries that are stable, quite stable. And then we don't need to use this splint for so long. So that is Sophia, 15 days after surgery. Remember that she went to surgery with the brackets and the IPR done. Now we removed the DATs, as we can see here. Look, these red circles were the DATs. I mean the mini screws, right? So here we see this condition where the first set of aligners were inserted on the patient's mouth. So here the surgery first orthosurgical treatment, inserting mini screws, the TADs, as I mentioned before, for post-surgical intermaxillary fixation. And I kept the surgical guides for 15 days, as well as the screws, the TEDs. Nowadays, if you are quite insecure, you can keep the TEDs for a little bit longer. It doesn't spoil the ortho movement at all. But now I can insert aligners. And I need to insert aligners as soon as I can. Why? To speed up the ortho treatment. Why? Because I have the wrap, as we're gonna see later. Gui, how quick do you change the aligners on that stage? I change it at least 2 times a week. If the patient is young, I change 3 times a week. And we know that we have a window of approximately 3 months to speed up ortho treatment. Why? Because we have this regional acceleratory phenomenon. We induce some trauma in the bone tissue. So we have this wrap because of osteopenia. This bone tissue has lower density, and now we have facilitated orthodontic treatment. That's why I love to treat my orthodontic surgical cases with aligners, because I can change them and speed up ortho treatment a lot. And that's why I don't bond braces in that golden period. Look at the patient, pre-operative and post-operative, 90 days, pre and post 90 days. Beautiful profile, in my opinion. Oh, she still had some gummy smile. Remember, she's 17 years old. Here's the panoramic x-ray 3 months after surgery, and the final result. 6.5 months of treatment. So she traveled to Spain to live there with the whole treatment completed. Here's the final result. The final panoramic image brought from the CBCT. The final lateral cephalogram. Here's the final condition in the CBCT. And here you can see the CBCT images, rendered images. As you can see, more harmonic positions of the maxilla, mandible, and teeth. Okay, there you are. And now, class 1 occlusion on the right side. And the patient, I do not need to say that, was thrilled, really, really happy. Initial and final conditions. Initial and final conditions, 6.5 months of treatment. There you are, initial and final positions. Initial and final. Here the class 1 sagittal relationship was achieved. Here we can see the overjet was corrected. Midlines are on. So that's why I said before the 3D digital orthosurgical planning is great. Aligners for surgical procedures are great. They lead to excellent results, in my opinion. So the initial and now 1 year post-treatment. I mean, that's the initial and look, the initial condition and 1 year post-treatment. This is great. She came to Brazil again for her holidays, vacation. And I was able to take some shots, take another extra photographs. There you are. And happy, happy, happy. Referrals. After her, I treated her brother, her mother, and 2 of her friends, close friends. To close this astonishing time I had with you, my friends, I'm gonna finish with these take-home messages.
I,
Aligners, in my opinions. Well,
dear,
sorry.
I think you sent me. I have two cases, but you presented one case, and I think you case one case you have or not.
No, I skipped one case. Okay.
If you
Is
want,
that what you asked?
there's
Sorry.
no problem. Time is
No,
not.
I've skipped one because I had an hyperlink. Then I jumped that case.
Okay.
Is
Okay.
that what you give?
Okay. Yes, there's no problem. Okay, please go on.
Another opportunity, my friend. I'm gonna visit you in Turkey soon.
Yes, we wait. You know, you have a great guy in Turkey. Please go on, dear.
So, in my opinion, Invisalign is for simple cases like class 1 with crowding, and simple. I wrote here like because it's simple for people who are trained like good orthodontists, like you are, and also for complex cases, as we saw here along these last 2 hours, class 2, class 3, open bites, deep bites, asymmetries, extractions, vertical, uprighting molars. That was the other case, that was uprighting molars with extractions and orthodontic surgery cases, okay? We have now technology. Some people claim, oh, it's gonna overplace orthodontists. No, it's a big friend of ours, and we need to take advantage of these technologies, okay? Why? Because if you are afraid to do this change, I must ask you, what if I told you that 10 years from now, your life would be exactly the same? I don't think most of you would be satisfied. So why we are afraid of these changes? Move on, change your minds, try. We are all great orthodontists. Let's try and play with this new tool. Thank you very much for the Turkish Aligner Society. Thank you very much for Keith for this kind invitation. I hope that you all enjoyed our time here together. This is the link for the Aligners Expert. It's in Portuguese, but it's a 100% online course that I'm going to launch soon. Okay?
Thank you. It was so impressive and so detailed webinar, you know, because I'm loving webinars, but the detailed webinars I'm loving too much. Thank you very much for questions. And if you want, we can start. And also, which malocclusions cannot be treated with Invisalign?
It's not Invisalign who treats the malocclusion, it's the orthodontist, right? There are some malocclusions that are more difficult to be treated with Invisalign. And I must say that they are difficult to be treated with any appliance. Specifically like extraction cases with great control of torque and intrusion. In my opinion, these are the most difficult cases. Deep bites that have spaces and I need to retract those teeth. These are the most difficult cases, in my opinion. Okay, so in those cases that I have the idea that I'm gonna face big problems, I try to convince the patient to do micro-osseo perforations and Propel and VPRO 5. I know it's a topic that is really controversial. My good friend Daniel Ramos works a lot with that, but many people on the literature, and I'm very scientific, they claim that it doesn't work. I have a clinical opinion that it works. Not in all cases. Some cases I don't see much changes after using these protocols for MOPS and high frequency vibration. But in many cases I see great changes.
Okay, thank you. What do you think about putting attachments in the lingual side?
Recently, I read a paper that agreed with my opinion. I don't use attachments in the anterior teeth because of the anatomy of those teeth. And this article that analyzed images, CBCT, microimages, came up with the idea that the fit is not is not adequate there for placing attachments. And that was my belief previously, and this article confirmed that. And this article also claimed, as I was doing clinically my patients, that best fit would occur in the premolars and molars area for placing attachments on the lingual sides. So I know there are great guys like Dr. Fournier in Canada that works greatly with lingual attachments, but I don't use them in a frequent basis.
Okay, thank you. Another question is, how much time does it take to take the course with Invisalign? I tried to register in Romania, but it doesn't work. Can you help me with the registration? I think this is very special question. If you want, also this is the anonymous attendee. You can write the Invisalign center. This is not the question of the Guilherme. Thank you.
I think that this request will be easily solved nowadays, because at least here in Latin America, they are doing a lot of online registrations, right? And online courses for people who are willing to start working with Invisalign. So I'm not one of these guys that do this initial training for new orthodontists. In Brazil, I'm not a speaker for Invisalign for that purpose, but I have many friends who are, and they are doing a lot of online courses, but in Portuguese. So I don't think will help this person that is asking you that, Dr. Akif.
Okay, thank you. What course did you attend for 1 year in 2016 for aligners? I think it's Maziar Moshiri course.
Yeah, he has a specific course inside St. Louis University, but it's not open for students. I was there because I was doing my postdoctoral fellowship. It's a regular program that I need to do some tests and applications, and it was quite strict. I had a specific research project there that was about facial asymmetry, smile asymmetries. And as I was there, I attended many lectures, including Dr. Moshiri's inside St. Louis University. So it's a program of Dr. Moshiri inside the ortho program. Okay, Dr. Moshiri is the person who is in charge for this aligners training for the residents, and he is also in charge for most of the Invisalign treatments in St. Louis University. St. Louis University, they have like a partnership with Invisalign, and Invisalign provide many cases per year for St. Louis University, as well as Invisalign provides for many American universities and ortho programs there, right, Akif? So it was great to see many cases being treated by an expert like Dr. Moshiri.
Yes,
so
I know.
He opened my mind, as I mentioned before, that I could treat everything using aligners. And when I came back to Brazil, I adapt some of his protocols, because as we know, every orthodontist has his own way of treating things. And I adapt and I implemented, and I thought, and I could see that these protocols can be reproducible. I can reproduce them very, very safely. And that was my idea, to do this online course, the Aligner Expert, for the Brazilian orthodontists. So yes, now actually, I'm finishing the last stages, and I'm going to launch it soon, because I think it's important to share. He shared with me, right? He shared with me, he shared with the students, And I think that's our main goal. Our knowledge is conducted to the patient's mouth mainly. We change their smiles, their lives. But somehow, as I'm into the academic career, I was willing to do that. And this pandemic situation just came with the idea of doing that to spread it easier.
Yes, I speak with Dr. Moshiri, and also he accepted my invitation for this webinar series, but he said, man, Dan, I was working for 14 hours in a day. Actually, I cannot I cannot go to bed for sleeping because I'm very tired. And actually, maybe in the future, maybe he will give a webinar. He is very nice man, a kind man. I think he has a the intensive fellowship course. He has a lot of big guys, lots of big friends, and also I take this course in the future. I think it will start the new course in September 2020.
Yes.
After 3 or 4 months, I'm not sure. I will look my page, and then I really they have the very big guys like Nicosidis. I'm not sure his name. Also, they have lots.
Jonathan Nicosidis.
Yes, amazing doctors. I'm knowing all series of them. Another question is,
my friend Akif, you already know everything about orthodontics, my friend. Orthodontics is you're a professor of orthodontics. You know everything, but I must say that we are always learn while we do orthodontics, while we chat with people like we are doing today. I learn a lot when I reanalyzed, rescan my patients. I mean, when I oversaw them and again. So this is how we learn. We learn while we teach, we learn while we chat, but you already know everything. But it's always nice to be humble as you are and to keep moving forward, because I'm learning about aligners. We are all learning because it's like it has been developed like 20 years ago. We are now mastering the plastic, but how it changes, the speed it changes, the technology must keep us all aware of these changes, and we must share this knowledge, because doing so we will learn faster and better.
Perfect. And also, have you ever treated the class 1 distalization case, upper and lower distalization in case of lack of the space or protrusion? How would we approach and stage that in Invisalign?
It's a class 1, right?
Yes, with class 1 distalization case.
Okay, no extractions, just distalization.
Yes.
So if it's a class 1, if it's a class 1 with distalization, I must assume that we will need like temporary anchorage devices. So, yes. Right? So we can distalize as a whole, or we can do sequential distalization. It will depend on the amount of retraction and distalization you are willing to promote. One thing that is really important when we deal with lower dentition distalization is to ask a CBCT to analyze the contact of the last molar with the cortical plate. Most of people believe on the clean check, but don't analyze the basic principles for orthodontic diagnostic, right? So you must analyze the position of these roots with the cortical plate. How? Asking a CBCT imaging of this teeth. So adding some information to the question you just made me, plan it. Plan the amount of retraction, plan the bone that you have to retract those teeth.
Okay. Why is the aligner expert is not in English? I think you
maybe soon, my friend. I don't know.
soon.
My nights are being used to develop it in Portuguese. It's a big effort to put on paper or on screen something that I'm very demanding to myself. So I'm preparing an unique course. Maybe in the future, who knows, right? Maybe you help me, Akif.
Yes, maybe. Who knows? Thank you very much.
Who knows?
Guilherme, thank you very much. And also, you have a friend in Turkey. You know, I'm living in Istanbul. And also, when you come to Istanbul, please call me. You have you have my WhatsApp numbers. And also, we can all the times speaking and talking about aligners and all orthodontic items, titles, and etc. And tomorrow also, if you want, I can invite you for the Dr. Thomas Dreschler. He's from the Germany. He's also, I think, expert in Invisalign, nearly 20 years. I think he is founder of Invisalign.
There you are.
Yes. When I speak to him, I'm speaking this. So I am joking these items in these items. Okay. Thank you very much for everything, for your kind webinar, and also you are so kind. I'm knowing you nearly 4 years, but I think we are going to maybe for the 20 years. I'm not sure. Thank you very much.